All right. Hello, everyone. Sorry, we started a little bit late, but welcome to today's session. My name is Tessa Janovsky. I'm a PAC with Arizona Liver Health in Phoenix, Arizona. Today, we're going to be talking about MASLD and MET-ALD and how these definitely coexist in our clinics and how we can better identify these patients and ultimately better manage these patients. So let's jump right into a patient case. So this is 52-year-old female, Ashley. She was referred to us for an evaluation of a abnormal abdominal sonogram showing basically evidence of fatty liver. She, like I said, 52-year-old female. She's got a BMI of 29. Looking at her medical history of PCOS, hypertension, hyperlipidemia. She takes medications for amlodipine, and she's on a statin. She does take a multivitamin, and she's also on milk thistle. On exam, you don't really, nothing pertinent. Abdominal exam is normal. When you do a social history, you see that she tells you that she averages about 2 glasses of wine a day. So already here, just with this patient presentation, very common in our clinics, we can see that your light bulbs are turning on as far as metabolic disease, right? So we can already see that she does have a metabolic burden here, insulin resistance with PCOS, hypertension, hyperlipidemia. Looking at her vitals, her blood pressure is a little bit elevated. Her weight, 161, 5'2", her BMI is 29. On her labs, she does have elevation in her liver chemistries. AST is greater than ALT. A lot of times that will give you an idea of maybe this is more alcohol related. Her alk phos is also a little bit elevated, and her T-bili is also a little bit elevated. So this would be what we call a mixed hepatocellular and cholestatic pattern with labs. Her platelets look okay. Her hemoglobin A1C, this wasn't on her medical history, but we can see that she is indeed in that pre-diabetic range. And her triglycerides are also a little bit elevated. We want them to be greater or less than 150. So at 185, she does have elevation in her triglycerides. So we do have a FibroScan on Ashley. It looks like she does have a severe amount of steatosis, and her kPa or kilopascals is 11.4. So this is concerning that she definitely could have more advanced fibrosis. And so we can assume that with this FibroScan, there's definitely probably some liver damage going on. So reviewing the updated nomenclature for steatotic liver disease, the steatotic liver disease, or SLD, being the umbrella term to kind of capture all patients with hepatosteatosis from different varying etiologies. And so we've talked extensively about MASLD and MASH, patients who have those cardiometabolic risk factors who do not consume excess alcohol. Today's talk will focus on the MASLD and increased alcohol intake, or the MET-ALD. We also have the alcohol-associated liver disease, or ALD, and then other specific etiology, DILI, monogenetic diseases. And then there's some cases where we really don't find a reason for the steatosis. And so again, the purpose today is to really dive into the MET-ALD and what that means as far as alcohol intake. And so this, in clinical practice, this really is a kind of dynamic range as far as their alcohol intake. And so with this, people can be more MASLD predominant, and they can also be more ALD predominant. And so it breaks it down based on weekly and also daily consumption. So as far as on the left side, basically on a daily basis, you can think more than 1 for a female or more than 2 for a male. And then all the way on the other side, as far as daily, you'd be thinking more than 3 or 4 as far as for female and more for men. And so, the condition of MET-ALD really provides an opportunity for us to kind of better define the natural history of these patients and the development of biomarkers and therapies that are really currently lacking in these patients. And so, what is a standard drink? So, we get asked this all the time in clinic, and this is different across each country, right? So, this is based on the United States as far as what is a standard drink, is defined by basically about 14 grams of pure alcohol. So, although this kind of pitchers, different sizes, each contains approximately the same amount of alcohol and counts as one US standard drink or one alcoholic drink equivalent. So, for example, a 12 ounce of regular beer, this assumes that 5% alcohol content. And with beer, we really have to be careful because there's many different types of beers out there, especially the IPA drinks. They will have a higher alcohol content. And so when we talk to patients about their intake, if they say, "Oh, I just drink beer," we need to really dive in and say, "Okay, well, what type of beer? Is it two light beers or is it two IPAs?" Because that can definitely um, have a difference as far as how much total alcohol they are taking in. As far as wine, 5 fluid ounces, assuming 12% alcohol is equal to one drink. And then all the way on the right, we have the distilled spirits. So 1.5 ounces, basically one shot would be one drink. So looking at the mechanisms in this kind of dual etiology, so while MASH and alcohol-related liver damage have different kind of initiating causes, they share overlapping mechanisms of injury that drive inflammation, cell death, and progressive scarring. On the MASLD side, we have the metabolic risk factors, insulin resistance, central obesity, diabetes is the big one, our food, if they intake a lot of high fructose corn syrup, also genetic susceptibility, if they have any of the polymorphisms such as the PNPLA, that could make them more at risk for fat on the liver. Coupled with alcohol intake, this basically causes a disruption in the hepatic lipid handling, which leads ultimately to oxidative stress, endoplasmic reticulum stress, and hepatic death. So kind of coupled with activation of this reactive oxygen species that really play key mediators of cell death. And so couple this with the gut microbiome, which we know that diet and alcohol can disrupt the gut microbiome. All of this together basically causes this inflammatory cascade, which leads to accelerated fibrosis and ultimately disease progression. And so the drivers of liver disease, as far as the difference between MASLD, MET-ALD, and ALD, you can see on this chart, they're really patients who have alcohol use or alcohol liver disease have more than 3 times risk of decompensation. And so you can see as the fibrosis level or the fibrosis score goes higher, that increases the risk of decompensation. But in patients with MET-ALD, for example, who have more advanced liver disease, their 5-year risk is 10 to 30%. Compared to MASLD alone, which is about 5 to 15%. And if they have ALD, it's 15 to 50%. And you couple this with kind of the dynamic spectrum of steatotic liver disease as far as other disease drivers like genetic susceptibility, obesity, those metabolic risk factors, all of these together, again, will make for increasing morbidity and mortality in these patients. So this was an interesting study. This was a study that was done in Europe, actually. And this was before the new nomenclature, but so they basically looked at self-report versus, or basically used biomarkers as far to test alcohol. And so alcohol intake was assessed using the ethyl glucuronide in hair and also in urine. And the utility of these were measured against the audit-C, as well as other different lab values like the MCV, GGT. And based on as far as when they looked at the patients who have more MASLD, they saw that 28% of NAFLD patients actually consumed moderate to excessive alcohol consumption. And then when they looked at all these patients, as far as 25% of the MASLD patients. So really, it shows that self-report alone does not give us the most accurate information. And we need to, really have other biomarkers that we can use to assess these patients, and so we can better treat them. And based on, the area under the curve, really shows us that good diagnostic performance with these measures, especially the hair. And also the urine. And so those coupled with the audit C were the best markers that they used, that they found to kind of detect alcohol use. And they found that the lab values, the MCV, the GGT really weren't useful, and can be skewed for other reasons. And so again, at the end of the day, this tells us that we definitely could be missing patients who would be categorized as MET-ALD and not just MASLD. Looking at gaps in the assessment of MET-ALD, and so we know, with MASLD and MASH, we know about the metabolic risk factors. We know that is what we need to be looking at first. But also, part of this should be an assessment of true alcohol intake. And so when we look at metabolic risk factors, if we only see isolated hypertension or triglyceridemia, and we'll talk about this a little bit later, we could possibly be missing or misdiagnosing. We may be making the right doses. And so again, we'll talk about this a little bit later, but if they have isolated hypertension or hyperglycemia, maybe we consider PEth testing. And we could find undisclosed alcohol use. And if we do, then they would be more categorized in that ALD. And so now we'll talk about which alcohol biomarkers that are being more widely used in this patient population, which would be the PEth test. We do a PEth test on our patients. Let's go back to Ashley. We do a PEth test, and she does fall into the moderate to heavy alcohol consumption with a score of 120. Oops. So as far as the PEth test, the PEth test has been reviewed extensively and is proven to be a valid test among many populations. This was looking at a study of the PEth's potential in abstinence monitoring by performing a drinking study to assess the detection window of PEth after ingesting a defined amount of alcohol. So basically, after 2 weeks of abstinence, a group of 16 volunteers ingested a single dose of alcohol. And so then they looked at the blood alcohol consumption, and in the weeks that followed, they took blood and urine samples daily. And then in the second week, it was every other week. So it showed that the PEth was detectable for 3 to 12 days after one single binge, if you will, 2 drinks, with a mean half-life time of 3 days. And so, we know that the PEth can measure amount of alcohol over the past 4 weeks or so, but this shows that this is a great assessment of abstinence, as well as heavy drinking. And good to note that there was no significant variability by sex and BMI. So this shows that the test can be used on a large population. This was an interesting study, basically looking for alcohol use in obese patients, and basically they wanted to see if they were missing alcohol use in an obese population. And so they enrolled about 659 patients that were screened. They eliminated patients who were never drinkers or kind of were missing data. And so they basically used the endpoints in the MET-ALD kind of cutoffs. And so looking for females who had reported between that 140 to 350 and males 210 to 420. And so they did a PEth on all of these. And of those patients, about 97 of them were analyzed, and they would be categorized as MET-ALD. And so that was about 15.7% of patients that were at risk for MET-ALD. And so that's one of every, 6 patients could potentially be misdiagnosed or think we're just dealing with MASLD or MASH, but really we're dealing with MET-ALD patients. And of those patients, it was interesting because about 79% of patients had some sort of identified alcohol use by PEth, and only about 21% of patients self-reported. So you can see a large discrepancy in that number. And if we only go by self-reported, we're missing a lot of patients who unfortunately could be intaking more than really they think they are. So going back to our patient, looking, kind of zoning in on her metabolic risk factors, what effect does alcohol have on these metabolic risk factors? So looking at alcohol and hypertension, this was basically a review looking at 32 different randomized controlled trials involving about 767 patients. And it was found, they basically looked at the effects of low dose alcohol, medium dose alcohol, and high dose alcohol, and what it does to the heart rate and the blood pressure. And so it showed that it does have a biphasic effect on blood pressure. It decreases the blood pressure up to 12 hours after consumption, and it increases the blood pressure greater than 13 hours of consumption. And also, as far as heart rate, kind of in all situations, it increased heart rate a little bit. So, what's important to kind of note on this trial, though, is that the findings were the majority of patients that were included in this were male. So these findings, they said at the end in their trial, these findings are relevant mainly to healthy young males, as there was only a small amount of women that were included in the trials. But for example, if you see a young male who is on blood pressure medication in your clinic, and that they only have history of high blood pressure, and you find that they do have maybe consuming a little bit more alcohol, maybe the blood pressure has an effect based on the alcohol, and is that metabolic risk factor present if we remove the alcohol? Looking at alcohol and hypertriglyceridemia, this was basically looking at the effect of moderate alcohol intake, so about 2 standard drinks of consumption compared to water on patients, and fasting triglycerides in patients with and without a history of hypertriglyceridemia. So what they found was in those who had normal triglyceride levels, alcohol caused a significant rise in about 50% in fasting triglycerides several hours after ingestion, which whereas in patients with history of hypertriglyceridemia, triglyceride levels did not significantly rise compared to water. So alcohol also reduced circulating free fatty acids in both groups, and this was cited to be likely through the metabolism to acetate. But the findings suggest that baseline triglyceride status strongly influences the lipid response to alcohol. So moderate intake can acutely worsen triglycerides in otherwise healthy individuals, but which is, although transient, it does come down, but has little effect on those who already have hypertriglyceridemia. So going back to our patients, kind of putting everything together with all the lab values, and see that, again, the PEth was 120. So she had reported that she averages about 2 glasses of wine a day. And so this, although we initially maybe were kind of thinking more MASLD, but she definitely has MET-ALD with kind of more MASLD predominant etiology. And wine, I would say, with our patients is tricky. We always, in our clinic, we always ask, do you measure your pores a lot of time, or how big is the wine glass? All those, fun questions we have to ask patients, but it's very important that we ask them, because that gives us an idea of, okay, if you don't measure your pores, maybe you are getting more than 5 ounces, those types of things. And at the end of the day, I think patients just don't really know, bringing that education forward as far as teaching them what a standard drink is. And so the next time they go to pour that wine, they can kind of see whether they are indeed getting more than the recommended intake. So what questions to answer? So what are the current treatments for this patient? So again, she has a metabolic burden, prediabetes, high blood pressure, high cholesterol. She's overweight, borderline obese. And so the mainstay of treatment in everything we do, right, is dietary, focusing on the Mediterranean diet, talking to her about exercise and overall weight loss, right, can help all of these things. Is she a candidate for resmetirom? Yes, that's something that we consider definitely. And what are your recommendations regarding alcohol use? It would be just stop altogether, especially anybody with more advanced fibrosis. Even, any amount of alcohol we know is just not going to be beneficial for the liver. And so the goal should be none, whether they work to get there, or what have you. But the goal for this patient would to be have no alcohol intake. And does she need HCC screening? Absolutely. She needs to have at least annual screening to screen for HCC. So what's the ideal MET-ALD definition for clinical trials? And this is an area where I think there's a lot of unmet need there's in clinical trials. So the definition should be based on objective biomarkers. We need to have biomarkers and that we can categorize patients, because often self-report underestimates the amount of alcohol that is used. And so this way, if we have biomarkers, we can really standardize the process and standardize the assessment. And we can also keep track of, we can use these biomarkers periodically, so we can certify that these patients are truly not drinking. And so we can monitor periodically in trials as well. And so ensure that drivers of liver disease are present. So maybe consider more than one metabolic risk factor. And also, if they do quit drinking, ensure that the hypertension and hyperlipidemia are persistent after the stop of alcohol. Does their medication need to be adjusted? Those types of things. And then considering exposure. So, within the past 6 to 12 months, as far as fulfillment criteria. Take-home message, there's a new definition, MET-ALD. So this takes, these are patients who are beyond, these are patients that intake more alcohol than the MASLD definition allows, which would be about 140 to 350 per week for women and about 210 to 420 for men, respectively. Clinical criteria underestimates the amount of alcohol that patients intake. And so really we need to, I think there's a huge push to kind of make this standard of practice, make it part of the liver workup. It just gives us more information so we can accurately assess and treat these patients. Really take a deep dive into their metabolic risk factors and ensure that drivers of liver disease are present, and then reassessing over time. Every visit, we should be assessing their metabolic health. And then as far as clinical research, really adding alcohol biomarkers to really classify these patients. We know that we can use these in different sociocultural backgrounds, men, women. We know that it's a reliable test. So at the end of the day, the more information we know, the better we can treat these patients, because these patients definitely are kind of underserved in clinical trials, and we need to do better for these patients. All right, so visit the GAT MASLD MASH Community Network for additional disease state education. That's the QR there. And that is it. Does anybody have any questions?